Welcome to the ACI Alliance Tuesday Talk. This webinar is being recorded. I'm your moderator, Morgan Gilmore. I am in the Navy. I'm currently completing a general surgery residency program, and I have been a cochlear implant user for 1 year. I have a single-sided deafness in the left ear. This talk is a part of an ongoing series for parents, adults, and with hearing loss, family members, and others. I hope you learn from this session and consider getting involved in the work of ACI Alliance. Next slide, please. First, let's review the technology and go over the Zoom settings that will help you. To access closed captioning, first click Settings in the navigation panel at the top of the screen. Then under the Meetings tab, verify the closed captioning should be enabled. If not, click the toggle to enable it. To ask a question, use the chat box and type it in. Next slide, please. American Cochlear Implant Alliance is a unique organization focused on cochlear implants across the care continuum. We were founded because it was felt that cochlear implants fall through the cracks at other hearing health organizations, and we wanted to focus attention on improving access to CIs. The mission of ACI Alliance is to support research, advance awareness, and advocacy. You can see that on the slide, there are also military members and veterans included. Next slide, please. CI-CAN is the CI Consumer Advocacy Network. It is for adult consumers and family members of recipients, including parents, aimed at enhancing and enlarging the broader advocacy efforts with firsthand knowledge of cochlear implants. Personal stories make the difference in impacting the decision makers, and it adds credibility in our contacts with state and federal representatives on key issues. If you're interested in learning more, then please let us know in the chat box, and ACI Alliance staff will follow up later. Next slide. We also wanted to share a few of the ACI Alliance website resources that are available. Next slide. And now we're delighted to introduce our featured speakers today. Cyndi E. Trueheart is a clinical audiologist and section chief of the Audiology and Speech Pathology Department at the Connecticut Veterans Administration Healthcare System. She earned both her Bachelor of Arts degree and her Master of Science degree from Southern Connecticut State University and her Doctor of Audiology degree from Central Michigan University. Over the past 22 years, she has presented at numerous national and international conferences on the topic of adult oral rehabilitation. Her particular areas of interest include cochlear implants, telemedicine, and rehabilitation of veterans with dual sensory impairments. Douglas M. Hildrew, MD, FACS, is an assistant professor at the Yale School of Medicine and the section of otolaryngology, head and neck surgery, who specializes in otology, neurotology, and skull-based surgery. Dr. Hildrew earned his medical degree from the State University of New York in Syracuse, New York, and completed his residency in otolaryngology, head and neck surgery at the Tulane University School of Medicine in New Orleans, LA. In addition, he completed advanced fellowship training in otology, neurotology, and skull-based surgery at the University of Pittsburgh Medical Center, UPMC. Dr. Hildrew is board certified in otology, neurotology, and skull-based surgery by the American Academy of Otolaryngology, head and neck surgery. He serves on multiple national committees and has been the chairperson of the telemedicine committee for the American Academy of Otolaryngology since 2019. And now I'll turn it over to the moderator, or to the presenters.
All right, thanks for that wonderful introduction, Morgan. Also, I just want to thank Donna and Nicole and Laura for having us. I know Cyndi and I are both pretty excited. You can go to the next slide. So, Cyndi and I are excited for several reasons. One, it's nice to talk about what you love in life, so that's always wonderful. But also, I think the VA is seen by a lot of the, I'll say the civilian side, even though I'm a civilian, the non-federal government side as a black box that they don't completely understand what goes on behind the curtain. But it's not by deliberate design. It's just that the VA is a large organization. So, it's actually crystal clear what we do and how we do it. So it'll be a great opportunity to just kind of talk about the model we have set up and, talk about some of the lessons we've learned and the system that we've designed over the last 5 years plus since I've been here that we're extremely proud of. So learner outcomes for this presentation. Outcome number 1 is to describe the current cochlear implant candidacy for veterans through the VA system. You'll see obviously a lot of common themes here. Some of this, it's a mixed audience, so some of this you guys might know by the back of your hand. Others, are still in the learning phase, or students, and this will be a nice resource for them as well. Learning outcome number 2 is to talk about how we counsel our veterans on the options for receiving cochlear implant services, what we do. And learning outcome 3 is to describe our new VA initiatives in the management of our population. And we really rely heavily on telehealth and community care services. Interestingly enough, this is not a result of COVID. We were really, I think we like to brag as trendsetters here. Before COVID, we had a huge initiative, and to our knowledge, we have the largest tele practice of cochlear implants of anyone. It's really quite robust. Next slide. So I'll be discussing outcome number 1, and then Cindy's going to take over for outcomes number 2 and number 3. So the most important thing to know is that the VA, Veterans Health Administration services are really vast. So I know this isn't a hearing aid lecture, but I'm going to plug hearing aids for a quick moment. If you meet someone who, you get the feeling might be a veteran, maybe they have a Marine Corps jacket or a hat describing where they served or who they served with, or, sometimes that age demographic can kind of lead you to believe someone might be a veteran as well. And you're thinking about setting them up with hearing aids, just ask them first, is there any chance that you might be a veteran? Because if they are, hearing aids through the VA are hands down the best. I mean, they get the best money can buy. The VA has an enormous account with all the major hearing aid companies, and it's totally free, $0. Also, it's kind of like shopping sometimes. I mean, they can get anything they want. You're not bound by the same insurance protocols that you might be bound by. And we'll talk a little bit about that with cochlear implants as well. So please do your patients a favor. If you have a feeling or for a fact they might be a veteran, just ask. So the VA obviously offers complete hearing assessments as well as balance assessments. Not every location does balance, but oftentimes a lot of them do. Conventional hearing aids are something we do a lot of. We're the biggest account in the country, probably, I think, the world. We also service cross and bicross hearing aids, so not just standard hearing aids, and assistive listening devices. So that's not just hearing aids and cochlear implants. That's things for lifestyle, alarms that flash, pillows that vibrate, all that stuff, for connectivity and how to get around in the world if you're hearing impaired. We also have a very robust arm that does osseous integrated devices like the bone anchored hearing device. That's not the thrust of this lecture today, so we'll move on past that. And then cochlear implants, of course, which is what we're here to talk about. We also do oral rehabilitation. We'll talk a little bit about that, and tinnitus management as well, but tinnitus is out of the purview of today's discussion. Next slide. Cochlear implant candidacy for veterans. The first thing to know about is, although it looks a little bit like what CMS might follow with Medicaid and Medicare, it is not. It really follows the FDA criteria much more closely than it follows what governmental insurance agencies might follow. So it's important to know that. So there might be a little bit of differences here that you didn't expect, but we'll get into those. So we do an excellent job with that. We cover indications for cochlear implants. We're going to describe really as fourfold here. One is a traditional cochlear implant, traditional criteria. The second emerged several years ago, electroacoustic stimulation. So we do not only hybrid, but also, folks that were able to preserve hearing with a full-length implant array, electroacoustic stimulation. We have, we're very proud to say, moved on to include single-sided deafness. In the VA, we call it single-sided deafness / asymmetric hearing loss. So you'll see that throughout the slide. Sorry, I have a scratchy throat. I have a little one in daycare. And finally, bilateral cochlear implants, which is really just an extension of, what we've discussed before, but we will give that some time as well. Next slide. Candidacy. So as I mentioned, we don't strictly adhere to Medicare guidelines because we don't have to, but we do obviously have to strictly adhere to FDA recommendations. And that both of those things are important, but the FDA recommendations is where the VA tends to fall along the spectrum of candidacy. So it's important to know, sometimes people will look at the criteria for the VA and they'll say, I think this person would be a great candidate. They're really struggling, and they're in maximal aided conditions. However, they're just too good, and it's very frustrating because I feel like they've kind of fallen into the hole where it's not quite time yet, they're struggling. There is a workaround for that, an official workaround. So you can submit it to the official VA board. This is very easy to do. It can be done with something as simple as an email or a phone call, and then we walk you through it, but it's not a major time-consuming prospect. And we can discuss it nationally. And really, the VA is focused into treating each patient as an individual patient. I think, Medicare is burdened with, treating the population, but the VA is blessed with treating the patient. And so each patient will get their own review if you submit it. And it's a very wonderful process. So if you think someone would benefit, but they're not quite there, please reach out to Cyndi or I. Oftentimes you're right, and they will qualify. Next slide. Traditional CI candidacy for veterans, as we discussed, is what you would expect: mild to profound sensorineural hearing loss bilaterally, limited benefit from best aided conditions. So their best aided scores are worse than 50% speech discrimination in the ear to be implanted, and less than 60% in the opposite ear. We do recorded testing with AZ Bio, sentence recognition, presented at 60 decibels and quiet. The important thing to know there is that the VA is not, I know in the civilian sector, so half of my practice is at Yale, the other half of my practice is the VA. At Yale, we rely on AZ Bio with, a signal to noise ratio, either a 5 or 10. And the VA doesn't routinely do that. So strictly speaking, that's not part of the VA guidelines. So, we test them in quiet. Now, if you have a feeling that someone might fall apart in noise, you can go ahead and test. And if they do, as we said, please present it to the national group and we'll consider them on an individual basis. So, but we don't routinely do that. That's not part of our routine recommendations. Next step, or next slide, rather. So sorry. So there is variable criteria when it comes to electroacoustic cochlear implants. Also, items you've seen in the past. It covers normal to moderate sensorineural hearing loss in the low frequencies, because those are the frequencies you're trying to give them the acoustic stimulation in. And then they would slope off to severe to profound sensorineural hearing loss in the high frequencies, just like in the civilian sector. And 10 to 60% words in quiet at 60 decibels in the ear to be implanted is what we currently use. And this is for unilateral use only at this time. Next slide. And then, as I said, just recently, the FDA recommendations are changing or have changed for single-sided deafness / asymmetric hearing loss. This is definitely a unique patient population. So the candidacy guidelines do include these patients now. However, there is, the workup is a little different, and I think Cyndi will get into that a little bit as well. Next slide. So, with that being said, I'm very proud the VA includes single-sided deafness, because just in general, we don't expect any government to move quite as fast as private industry. But in this case, we did. So even though it's still emerging, we're seeing some great benefits with our veteran population. We're seeing speech and noise testing improve. We're seeing quality of life improve. And these things have been published in prior articles. The other thing to know, especially with single-sided deafness and asymmetric hearing loss, is we oftentimes forget the unique aspect of the veteran patient population. Veterans are truly a unique patient population. The population I have at my Yale practice is very different from my veteran practice. Veterans on average tend to be older. Unfortunately, there is a link with socioeconomic status, so that can be a challenge. And there is a strong link with more medical comorbidities, so more medical diagnoses that they're being treated for. And on average, veteran patients tend to be sicker than the average civilian sector patient. So we are finding, as the private industry is finding as well, that oral rehabilitation is extremely important for these patients with, for all patients with cochlear implants, but especially with single-sided deafness and asymmetric hearing loss. And we haven't published it quite yet, but we're seeing some pretty exciting data and some pretty exciting progress with oral rehabilitation. And there'll be quite a lot of the talk later on devoted to this. Next slide. As we discussed, every patient with single-sided deafness, every patient with hearing loss has their unique needs for rehabilitation. What we recommend, and we're about a little over a year into this, I believe, with doing oral rehabilitation. We recommend really the first 6 months, we like to have the veterans, our veterans, say that they're going to go through oral rehabilitation for the first 6 months with us. Each training session is about 30 to 60 minutes of training per day. And when we train with them, quite importantly, is we stream directly to their cochlear implant. As with all patients, the brain is, I like to tell my patients, the brain is inherently lazy. And if you have one ear that's really great and one ear that you're trying to rehabilitate, the brain is just naturally going to focus on the really good input coming from the good ear. And so we have to isolate that to the ear we're trying to rehabilitate. And that's really the best way to do it. Next slide. This is for Cyndi.
Great, thank you. So yeah, so as Doug had said, we do have two other options. If the veterans do not meet the traditional criteria, you can submit it to the Cochlear Implant Advisory Board. Or, we have had research studies going on. And so sometimes the veterans meet the criteria through our study. Throughout the country, there's all kinds of studies being performed at the VA. So it can also be that a veteran meets the criteria through an IRB. Next slide. So what is the general process for receiving a cochlear implant through the VA? Well, the general process, if you're near a VA that has cochlear implant services, is pretty straightforward. As you would imagine, you would go through a hearing test. If you're engaged with your VA center and you're just going through those routine hearing tests, it's the audiologist that is usually the first one to say, hey, this patient might benefit from a cochlear implant. So after the hearing test, if they think, it looks like this patient might fall into that criteria, they would refer the veteran to a cochlear implant audiologist. Now that can be within the VA system. So if you have those services right there at your particular VA, then we would do a candidacy eval like we do in Connecticut. We do the candidacy eval with appropriately fit hearing aids. We would want the veteran to do a trial of hearing aids first before we consider the cochlear implant. And if we find on that candidacy eval with the appropriately fit hearing aids that the hearing aids are just providing limited benefit, then we would move forward. And here at Connecticut, Doug and I make sure that we make this as streamlined as possible. So we have the ENT appointments and the audiology appointments when someone looks like they would be a cochlear implant candidate all in one visit. So I think this is ideal in the sense that, there's no lag time. It's not like they have to come in for an audiology appointment and then they get scheduled and they have to wait and then come back and see ENT. As Doug had mentioned, these veterans a lot of times have a lot of comorbidities. And so we want to make this as easy as possible for them and eliminate not only those extra visits, but also I think we would both agree that this way there's nothing lost in translation. So if I'm seeing the patient and he's also seeing the patient, it's right there in real time. We're able to evaluate the patient as a team and make those appropriate recommendations. And then we also have our surgical coordinator right there in clinic that can get the patient booked for surgery, go over any requirements for that. I think this makes the whole process just very simple and smooth for our veterans. Next slide. So what are the options? Okay, we know that if you are at a VA, if your veteran is at a VA that has cochlear implant services, it's what I just described. That's pretty straightforward and simple. But what happens when you don't have cochlear implant services at your VA? This happens. Some people are in rural areas where they have to travel very far to a cochlear implant center. And so in those cases, we do have other options. And those options are working with our community care partners and through telehealth. Next slide. So let's first talk about the process for community care. This is a mechanism that veterans can get cochlear implant services and other services, actually. Community care is a network that provides services that the VA might not have readily available. So it's not just cochlear implants, but we'll focus on cochlear implants here. So this mechanism is for providers out in the community to become one of our community care partners and provide cochlear implant services to our veterans. It's called the VCCP, or even just most of us refer to it as community care. And the provider on the outside can become part of this community care network. And that way, once you're part of that network, you're able to provide these services to our veterans. It's kind of like a third-party insurance. The VA is paying for all of it, and the provider in the community has to get that pre-approval first. But once they're in our network, it's really easy to refer to them if you don't have cochlear implant services nearby. Next slide. So what is the criteria? You know, we want to make it as easy as possible for our veterans. So the general criteria is based on two things. It's based on travel time. So if you are not near a cochlear implant VA center, you might then want to go get your cochlear implant through one of our community care providers. But the other thing is wait times. So we don't want our veterans waiting. So if a particular VA has a lot of patients waiting for a cochlear implant, we might use our community care providers in that instance too. There are some other exceptions as well. If the veteran doesn't meet the travel distance or we're able to see them in a timely fashion, there are some situations where I've worked with community care where it's just, again, those comorbidities, the veteran can't physically get to our center. We might have to work with some of those community care providers. And each state participates with community care to a different degree. So here in Connecticut, we don't deal a lot with community care because we are a full cochlear implant center and we're a small state. So if a patient lives in Connecticut, they're likely going to come to us for those services. We also don't have extensive wait times for veterans to get in. In fact, I think one of the things that Doug is known for is adding in extra surgery dates to get our patients seen in a timely fashion. He's often known to scoop up other surgeons' block time if they're on vacation or they're taking time off for the holidays. So we get our veterans in pretty quickly here in Connecticut. And the other thing is that the VA does hold its community care providers to a really high standard. So there is a process to become a community care provider. It's not extensive. You could become a community care provider for VA patients pretty easily, but there is a checks and balances kind of process to make sure that the veteran is getting the same exceptional care in the community that we would provide if we were able to give it to them at the VA. Next slide. So more about community care. What happens? Okay, you're at a facility. Your veteran goes to a VA facility, say for primary care, but they don't offer cochlear implant services or audiology services maybe at that particular VA. What would happen is that primary care provider or whoever the veteran is in contact with at the VA can put in a referral to community care. So there's a department, a community care department within VA that helps the veteran navigate the system. As Doug had mentioned, it's oftentimes difficult for outsiders to figure out the VA system. And so we have these people in our system that can help them navigate that. The community care department works with the veteran to say, okay, where is the nearest center that provides cochlear implant services? Are you able to go there? Even if it is quite extensive for you to get there, do you want to stay within the VA and get all your care done there? And then we can set up things like reimbursement for travel. Some of our veterans get hotel services if they have to stay overnight. If they're coming from a distance, then they can be set up at the hotel down the street, all paid for and cared for through the VA so that we take care of our veterans. So if they can travel, if they're willing to travel to the closest VA, they get all that set up for them through our community care program. They can also, opt to go into the community. So maybe they'll say, it really is, it's 3 hours for me to get to that nearest VA that offers cochlear implant services. What can I do? Is there a community care provider in my community, in my town, in the next town over that can provide these services for me? And community care would look to see who is in that community care network. And if there is no one, and the veteran knows, well, I see an ENT, maybe he'll want to become part of this network, then we can help him with that process. Like I said, the determinations are based generally on travel time and wait time in terms of how long, how much time does the veteran have to wait to get their cochlear implant. But there are other exceptions sometimes that we do make for veterans that are having difficulty getting to us. And then as far as any kind of payment, everything is covered through the VA. So everything that the veteran would get free of charge at the VA, if that VA had cochlear implant services, they would get those same things free of charge in the community with that approved community care provider, except that if they do pay a copay for their appointments at the VA, they would also still pay that copay with that community care provider. Those are generally $50 copays for the initial visits, but it's the same system. So if they came to VA or if they went to that community care provider, it's the same kind of copay. Next slide. So what else is covered? We want to make sure that there is that consistency if a veteran goes to their local community, their local VA CI center, or if they are going to the community care provider. And so we make sure that those community care partners know that we're a 2-processor center. The VA is, we always order 2 processors. We never want our veterans, especially our cochlear implant patients who are often very handicapped by their hearing loss. We don't want them to not have a processor available to them. So we do make sure that 2 processors are ordered, not only in VA, but also with those community care orders. And then as far as upgrades, the VA is wonderful that if there's something new that comes on contract, we can upgrade the veteran. Sometimes I make an argument that it's just a matter of, their situation has changed. Maybe they now wear full-time oxygen and they don't, they're having trouble getting the behind the ear processor on their ear. And now they decided, can I get one of the single unit processors? So it might be something like that. Or it might be something where there's some new technology available, and then we might, just upgrade the processor for that reason. So if we are doing processor upgrades, that is ordered through the VA. So that, again, is why that community care partner has to work very closely with their VA center to make sure all these things are ordered and available to our veterans. If you don't have a site nearby that you can work with, then it's that VA centralized audiology team that works with the community care partners so that these things can get ordered in a timely fashion for all our veterans. And as far as parts and accessories, any audiologist in the whole VA system can order those things. Sometimes we have patients are, not even patients, but other audiologists throughout the country that don't necessarily work with cochlear implants, but they'll call us and they'll say, I got a call from a veteran, you know, he needs a new cable, or he needs a new accessory, or, you know, something isn't where he needs an extra rechargeable battery or a mic cover. And any audiologist in the VA can order that, but many times they'll reach out to us and say, what am I ordering? I don't typically work with cochlear implants. And then we help them out with figuring out what the veteran needs and get that to them. Next slide. Okay, so a little bit more about community care. There is this website. If you are a provider and you want to become a community care partner with the VA, which I think you should, veterans are great to work with. Go to this website and you can find out how to become one of those community care partners to get that pre-approval to see our veterans. Or if you're a veteran and you want to find out more about, am I able to get this in my community? Who in my community might be a community care partner? You could go to that website to find out that information. The approval process, you know, we want to make sure that no one is getting unnecessarily charged for anything. So there is that pre-approval process. So make sure you are getting that pre-approval. You can't just go to your local ENT or your local audiologist and have them provide a service and then later on ask for that reimbursement. So we do get that pre-approval, or you want to get that pre-approval as the community care partner or as the recipient. You want to get the pre-approval. And we just want to make sure that everybody is following the same rules so that, you know, we're providing the same level of care to our veterans. And, you know, there have been some instances where maybe the community care provider was not providing the care that we expect at VA. And so then that's not someone that, you know, continues to be on our list of community care partners. And some of the things we've found in the past are poor follow-up to care, or, you know, just not getting the veterans everything they need. So maybe they're only, you know, getting the one processor versus the two processors. So they're not following those guidelines, or even just poor testing protocols and things like that we have found. And so we just want to make sure that our veterans are getting the best care possible. So there is a process for submitting those if we see that there's something that doesn't hold up to our standards. And then, you know, there's multiple networks out there. So this is a huge, huge system, this community care network. So when you go to that website, you'll see that there's so many people that have become our partners to get veterans cochlear implants. Next slide. All right, so one of my most favorite things to talk about is telehealth. While we don't work a whole lot with community care, specifically in Connecticut, we do a tremendous amount of telehealth. So as a full cochlear implant site here in Connecticut, we serve all of New England. So there's not a whole lot of partners even in New England. So if you think of way up in Bangor, Maine, close to the Canadian border, there's not a whole lot of ENTs up there. And so what happens in those cases, we get the veterans to come down to Connecticut and do that one-stop shopping. We make sure we have the ENT appointment, with the audiology appointment, with the surgical coordinator, with the nursing staff, with radiology, if we need to have CAT scans done. Everything is done in one visit. And then, you know, the veteran would obviously have to come down for the surgery and the initial activation. And then pretty soon after that, we can release the veteran to telehealth, meaning that they can go to their home VA site and we can see them through telehealth. So it's VA to VA. And so as the cochlear implant site in Connecticut, we would have the veteran go into their Bangor, Maine VA site, if that's their home base. And the audiologist up there would hook the veteran up, hook their processor up, their cochlear implant up, and then we would see them what's called clinical video telehealth. So it's VA to VA. We're seeing them through a system like this where it's video, and the veteran can see us and we can see the veteran, and we can map their processor from Connecticut anywhere in New England or anywhere actually in the whole VA system, we can map their processor. So it's really nice. We take over their screen and do that mapping. And we have that audiologist on the other end. It's just kind of our hands, and also to just reiterate things. So sometimes there is a little bit lost in translation through video, and the audiologist on the other end might just reinforce some of the things that we say. That's a great way to get our veterans the care that they need, and they don't have to travel to Connecticut for all of their appointments. We reserve the Connecticut site for the candidacy, the surgery, the initial activation, and then really just complicated cases. But most of them after that initial activation do some form of telehealth with us. There's another way we could do telehealth, and that's what we do with many of our veterans for oral rehab, and that's the VA Video Connect system. So that's the VVC. And so this is when I do oral rehab with my veterans, I don't need them hooked up to any kind of equipment as far as mapping goes. So I do auditory training, I do speech reading, all those counseling things as far as that oral rehab process is right into the veteran's home. So they can do it through a smartphone, they can do it through a tablet, they can do it through a computer. And it's a really pretty easy process, and we're providing care right into their home, right where they need it most through this VVC process. The remote mapping does require the veteran to go into a VA site. The veterans don't have the capability at this time to be mapped at the home. And then, like I said, our tele-oral rehab program, we've coined that TARP, can be performed at their home. Next slide. So what kind of services do we offer via telehealth? Just about everything you could possibly think of, except for obviously things like surgery. But so many of these other things we can do via telehealth. We can do mapping from site to site. We can do surgical site examination. Many times, Doug will have the spouse or a family member, or even just the veteran, hold their phone up to the surgical site so that he can see exactly how that site looks. Those, post-op appointments, even rather than having the patient come in where he just talks about, cleaning the wound or something like that, can be done over video. And that's a great way to reduce the travel burden on our patients. Otoscopy. So if the veteran goes into one of those other sites, we could do video otoscopy. Of course, implant counseling, whether they're thinking about a cochlear implant or post-implant counseling, we can do that all through telehealth. Oral rehab, like I mentioned, BAHA programming, hearing aid programming, all that stuff can also be done through telehealth as well. Next slide. So the equipment needed, the veteran just needs something with a video and a camera, so video and email. So what we do is we send a link to them via email, and at the time of their appointment, they're just going to click on that link and be able to see and hear us, and we see and hear them. That link is that HIPAA compliant space. It's, I think of it as like a virtual chat room with the patient. And this is great for those oral rehab sessions or counseling sessions. The speech pathologist does so much of that oral rehab through the VVC, so right into the patient's home, because the speech pathologist doesn't require any kind of equipment. They're not mapping anything, they're not hooking a processor up, so they just need the same thing, the video and some kind of email or internet connection with the patient. And the patient, that's all they need, but if they are being mapped, they do need to go into a facility. Next slide. I should mention that the VA also does provide tablets to veterans if they don't have that, in order to do the telehealth too. So most people have some kind of video at home these days, but there is a process for veterans to get a tablet at their home to do these telehealth appointments if they need that. So the virtual care manager is the program that the VA uses. This is that I set up an appointment, a date and time with my veteran. The morning of their appointment, they'll get that email, and then at the time of their appointment, we both get an email, and we just click on where it says join appointment, and it's that simple. They connect into us and they love it. Next slide. Why do they love it? They don't have to go anywhere. It's right at the comfort of their own home. So they don't have to travel anywhere. Travel is a big thing. You know, our parking lot is not the greatest. So they don't have to worry about fighting for parking. They don't have to worry about, you know, getting a wheelchair to be wheeled to our clinic. They don't have to, you know, worry about gas or, you know, anything like that. And so that makes it really nice for them. We generally have no missed appointments. So it's great for making sure that we're productive as VA providers. If a veteran cannot connect to us for some reason, you know, we know how internets can be sometimes, we call them. We call them and we do a telephone visit with them. Obviously video is better, but if we have to do a telephone visit, at least we're making contact with the veteran. And to this date, we've had absolutely no negative results expressed by the patients with our telehealth program. If anything, the only somewhat negative response would be that sometimes they miss just seeing us in person. And so they miss that human connection. But other than that, they really seem to love it. Next slide. So I'm glad I have a few minutes left as well to talk about something that I am extremely excited about. We have so many great things going on in the VA system. And I'm going to just highlight a few of them here for you as far as our cochlear implant program goes. Throughout the entire VA system, the entire country, we're doing this mentorship program. And this is something that is near and dear to my heart. It just started this year. We had over 50 applications into our mentorship program. So people that were looking to get their hands in cochlear implants, and we accepted them all. So the more experienced cochlear implant audiologists in the VA system came together. We formed a group to take on all these other audiologists in the VA system that had an interest and wanted to provide cochlear implant services to their veterans. So as part of this program, they do telehealth sessions with us to gain experience. They do some in-person sessions with us. If they're nearby, we try to match people up in terms of location. So if I have, say, an audiologist in Boston that now wants to start providing cochlear implant services, she's going to come down and see some hands-on stuff with us to get trained. We have calls and presentations so that they're staying up to date and they're getting all the information that they need. This program, while it is pretty extensive on the experienced cochlear implant audiologists in the VA, the whole goal of it is to create this network of more VA audiologists that will be able to provide cochlear implant services. So many of those centers won't have a surgeon. They won't be able to do the surgery, but they'll be able to do some of that follow-up care, that mapping, that programming, and then we'll have even more options for veterans in terms of getting the care that they need close to home. So I'm extremely excited about how that program is going. And like I said, in our first go round, we accepted over 50 mentees. So there was a great response to that initial rollout. And that's going to just continue with the next cohort and so forth. And we'll have even more. The next initiative that we talked about, and it's so exciting that we have Dr. Gilmore here, who also said that he is a single-sided recipient. This was huge, right? When this came out earlier this year about being able to get veterans cochlear implants if they were in that single-sided or asymmetric hearing loss category. You know, for many years, we thought, you know, if someone has a dead ear or a profound hearing loss ear, why not? Why not get them a cochlear implant? Why do we have to look at the good ear? You know, that ear is not functioning. A hearing aid is not helping it. Why do we have to wait? We know the longer we wait, the worse it is. So now that we can get those patients a cochlear implant sooner rather than later has been huge. So in the past, we did some studies, they'd have to go through an IRB. We might have to present it to the advisory board, but now we can just go ahead and proceed. So this has been great for those sudden hearing losses where, they went through their typical steroid treatments. We've tried them with the cross or a bicross. We tried them with traditional amplification, and none of those options, or even a softband Baja, and none of those options seem to be providing the benefit that the veteran needs. Then we can quickly move forward with a cochlear implant. We have seen with the short auditory deprivation, this is wonderful. It's kind of like a wow effect. They, immediately are able to navigate their world with that cochlear implant. But one of the things, as we pointed out earlier, is that the rehab for this is a little bit different. And so we want to make sure that our veterans are fully engaged in an oral rehab program that streams directly to that single-sided ear, to that cochlear implant in those cases, so that they don't fall back on their good ear, and so that they really strengthen up that single-sided ear that has that profound hearing loss. We do this by making sure early on that they have access to technology. So, many of our veterans are older, and so we do want to have that conversation with them early on before they get implanted about, what kind of cell phone do you have? Do you have a smartphone? You're going to need to stream directly to your cochlear implant to isolate that ear, to make sure it's working, to make sure it's actively working and not just kind of hanging back there and letting the good ear do all the work. I have also found with these single-sided cases that they get really kind of nervous. They want to move forward with a cochlear implant sooner rather than later, because in many of those sudden cases, they don't know what caused the hearing loss, and they're always afraid that the other ear might go. And so the sooner that they get on board with that cochlear implant and get used to that cochlear implant, they have less fear that, okay, if my other ear goes, then I'll get a cochlear implant on that side as well. But they know they're already back on the air with that cochlear implant. So it eases that aspect and gives them more peace of mind. So a lot of differences with that single-sided, that asymmetric hearing loss, but it's really nice that we can move forward without kind of jumping through a lot of hoops now that it's FDA approved. The other initiative we have going on is consolidating the CI databases. So throughout the whole country, we started doing this with national IT, so that, many of our veterans, like I said, many of my veterans are throughout New England, so they could go to anywhere in New England, and when the audiologist there hooks the veteran up, their maps are already there, their sessions are already there in that database. I don't have to rely on reading out a processor, or even in some cases, if the processor isn't working, now what do? Now I have to somehow get that map to that center. By having that information available no matter where you go in the whole VA system, really kind of streamlines that process for our veterans. And speaking of streamlining, the telehealth program, while we do that throughout all of New England, like Doug had said, we've done it before COVID, and we love working with our veterans that way. I think one of the things that is just amazing to me is that I can see a veteran anywhere, in any state, anytime. We're not bound by those state restrictions as far as I don't have a state license in, California. I can see a veteran anywhere because the VA is considered one giant healthcare system. So if there is a veteran that, doesn't have oral rehab anywhere nearby and they live out in California, I can see them. I don't have to worry about that state licensure because I'm in the VA system. So I can help them with their cochlear implant no matter where in the country they live. So we hope to get the word out there so that more veterans do take advantage of that and more VAs take advantage of that. We make cochlear implants a priority here in Connecticut. We have the staffing, we have the resources, to make sure that we can help these other centers. And, we designed a program so that, it's replicable. Other VAs can learn from us and they can then carry it out in their catchment area. But in the meantime, we want to start getting them the care that they need right now. So definitely spread the word. We'd love to help people out through telehealth, through our telehealth program. And then finally, as Doug had mentioned earlier, I can't say enough about our hearing aid and accessories program. I can't even imagine. I've been at the VA 22 years. I can't imagine having to sell a hearing aid. I just get my veterans whatever they need. It's about, we focus so much more on what do you need to hear? How can I help you navigate your environment? Okay, you have a cochlear implant, but let's also get a hearing aid now that matches up to that so you could bimodally stream. You're having trouble with the TV. Let me get you also a TV streamer. Oh, you go out to dinner a lot and you're having trouble in that environment. Let me get you a remote mic. There's so many things at the tip of our fingers that, many people in the private sector just, they have to pay for, or they have to jump through hoops to get it. And the fact that, I don't even have discussions about, the level of technology with my veterans. We always get them the latest out there. The contracts are updated twice a year. So everything that the vendors come out with that is new, we're able to get that for our veterans. We're able to upgrade them. And so that they have access to all that wonderful technology that's out there. And I think that's it. Next slide. Right. So to wrap it up, cochlear implants, right? This is something that everybody should be talking to their veterans about. So if they are experiencing limited benefit from hearing aids, we want to make sure everybody is recommending that you might be a cochlear implant candidate and find out how to get that veteran worked up for it through the candidacy evaluations. We also have a great network of providers. So whether it's through community care or through our telehealth services, your veterans can be seen anywhere in the country, and we're happy to help you navigate that process. If you don't find the information that you're looking for on that community care site, or if you don't have access to a VA center close by, reach out to us and we will help you figure out where the closest center is and how to get you started. Thank you so much. I think we have some questions maybe going on in the chat.
I handled all the chat questions as you were speaking.
Awesome, thank you.
And did some cheerleading.
We are the best cheerleaders. We love VA. So, being at the VA a long time, it is hard for people to navigate many times. So reach out to us. We'll help you navigate that system.
On that note, I'm not sure if there's any residents, in the otolaryngology residents in the talk, but, please consider the VA. It's really, honestly, it's the highlight of my week. I love it. I'm really quite blessed to have a really strong team, and that makes all the difference in the world. But it's a great place to practice. The veterans are wonderful patients to work with. The metrics are, very different from the private sector. So you really can spend the time you need with each patient, and it's just very rewarding. I really enjoy it.
Thank you so much for that wonderful presentation. We do have some chat questions that were answered in the chat, but the participants can't see the chat. So we can go through those in just a minute. I do have another question for you before we run out of time. We have about 5 minutes left. Dr. Hildrew, I'm a big fan of yours. I've read your studies and know about your work from before this talk was ever announced by ACI Allowance. So I thank you for the opportunity to hear you speak here. I just wondered, is there any initiative for active duty members to get the same technology for them? Because I will come on active duty when I'm done with my residency. And of course, I'm concerned if I'm deployed and need an adjustment for my cochlear implant or something like that, then, telehealth would be a huge help to those who are deployed, who are cochlear implant users.
Yes, let me just make sure I got the name correct.
I'm Morgan Gilmore.
So, oh no, I know your name.
Oh.
Yes, there is. So I'm less familiar with the Navy, more familiar with the Army, but through the Walter Reed system, Anthony Tolosano is a neurotologist who's in active duty and practicing physician. So yeah, he's down in the Walter Reed system, and I know he has a parallel set of interests through the DoD, the Department of Defense, and a similar thrust with his passions. So, if anyone is active duty, you can reach out to me. My email address is douglas.hildrew@yale.edu or douglas.hildrew@va.gov. And or you could reach out to Dr. Tolosano, who represents the Army side. But through the Navy, I know some fantastic physicians, but not all cochlear implant physicians. So I'm less sure there, but I can do some homework on that.
Okay. Yeah. Thank you for answering that question. Another question that I had, sorry, I'm don't mean to take up our time with my questions, but my other question was, are you engaged in any research currently to develop any user interfaces or like video game kind of interactive software for oral rehabilitation?
We are not. The research arm we have, and we have quite a lot going on right now, is most of the things that Cyndi has mentioned. Just first defining our telehealth practice and showing that the results are either equivalent or superior. They've never been inferior. So that, I think of that as something I really just have to do as a moral standpoint, because we have this great practice through the VA, and our metrics are different. Through the VA, I can ask Cyndi and one of our great partner audiologists in Bangor, Maine, to both block out an hour of their time and do telecare. I can't do that in the private sector. I can't ask someone to not get paid for their services. That's not fair. But through the VA, depending on which codes work for which parts of the visit, both people can get contact point. And so I really feel an obligation to, special obligation to try and discuss this to help, not only myself in the private sector, but all of our patients and all of the other providers in the private sector. And we're doing a lot of work right now with oral rehab through, spoken language and through some workbooks and progress there, but nothing with like an active kind of video game type setup. I think that there are some folks through the Walter Reed system that are interested in that and have the setup where they could do it. I don't want to put words in their mouth, but some of the conversations I've had, some of them have some of the PhD side down there have some really vast resources and knowledge, but unfortunately not with us right now, at least.
Dr. Gilmore, are you looking for something for you personally to help strengthen that ear, as far as like an interactive kind of website? Is that what you're looking for?
Yes, ma'am. My motivation is partially selfish, but I have an engineering background prior to going to medical school, and my degree is in design and engineering manufacturing. So basically, user-centered product design is something that I've always been interested in. And I feel like I have kind of cobbled together resources to create my own rehabilitation program. And it would be beneficial, I think, for a lot of people who are CI users and maybe don't have the same resources that I do, to have a single place they could go to get comprehensive oral rehabilitation.
Yeah, that's wonderful. I would actually love to talk to you offline about that. We're developing kind of our own little program here. It's not research based, as Doug had said, but it is more just clinically based. And so we've kind of partnered with all of the cochlear implant companies to pull a little bit from each one to make our own program that, fits our single-sided patients. And so much of that is that streaming, that, having access to different apps. I use a lot of the apps through the manufacturers with my single-sided patients. And, it's really kind of just trial and error at this point. For every individual patient, I don't want them to get bored. So, some of them are kind of silly sometimes, and that isn't going to last very long. Whereas then I'll just find something else that might be a little bit more interesting to my veteran, and so I would love to talk to you offline about, having you try out, if you haven't already, trying out some of those apps to see which ones you find useful, and just get some feedback so that we can continue to build that program and have that kind of structuredized, standardized curriculum kind of for our SSD patients, or any of our cochlear implant patients for that matter.
I think that would be a very powerful thing to do. Thank you.
Yeah, of course.
So we're just about out of time here. There are some questions that were already answered. Do the other moderators want me to go through them, or do we want to wrap up so that Dr. Hildrew can get to his other obligations?
I think most of it were things that I had said that Cyndi also said a few minutes later. So let me go through and say some of the important things. One thing is, it's amazing how much the veterans love the VA. It's not just a healthcare provider, it's a social network. They like to, get lunch in the cafeteria and see some of their old friends. And so, contrary to what you might think, coming with a private sector mentality, our veterans are oftentimes just more than happy to travel 3 hours to see us, which blows my mind. But they believe in the VA, they love us. We really go out on a limb for them and work hard to make it work for them. But one thing to know also is, for people that are traveling from a far distance from the VA, they don't have to. They could choose community care if they wanted, but if they choose the VA, it's quite easy for us to get them overnight lodging. So that's great. Sometimes, especially if it's like a surgery day, sometimes they'll stay the night before and then the night after. That way they don't have, some of these patients travel like 8 hours, they want to, like from Bangor, Maine, they like us and they want to come. So that's good to know that, we have their lodging covered should they need it. Cyndi mentioned about the state licensure because we're on federal property. Donna had asked a question about where the majority of our patients come from. So do we get a lot from private referrals to the VA? Clearly the vast majority of our patients, and Cyndi, I'll make sure I'm not lying, come from internal VA, because they're being followed by an audiologist. We do monthly meetings, we do educational things, we sometimes we have fun games with trying to educate ourselves on candidacy to try and find more people to help. And so we have a really great VISN, the VISN being New England, so Maine to basically the Connecticut, New York City line, and almost everything east of Albany, to be honest. So it's a huge swath of land, very populated. And so most of them come from within our VISN, and they're known to the VA. We do get a few that are referred outside. So a lot of veterans will have two types of insurance. They might have private insurance through work, but then also, VA insurance. And so sometimes they're already plugged into a system. They might use their private insurance to get the surgery, and then they present to the VA and it's like, hey, I got this cochlear implant. What can you do for me? And we can do anything you want. It doesn't matter where you got it. You're a veteran. Here's the shopping cart. So that's one group. Another group might be people that aren't registered at the VA currently, and we can definitely help them, but they're a little bit slower because they have to register at the VA. So if they're already registered, we can get them in 1 or 2 weeks. Honestly, it's a priority for us. If they're not registered, the VA has something called the patient advocate. And so, they need their discharge paperwork. And then, basically we give them the number for the patient advocate and we help them enroll. And it takes a few months, but a few months, and the alternative is, they're no longer in a loophole where they can't get help anywhere and it's free care. And so that process can take a few months just because you have to register for the insurance. There's no open enrollment time. You can do it any time of the year. It's not like in the private sector where it's got to be around Thanksgiving time in November. So they're, we can still help them. It takes some time to enroll them. Very rarely, if someone's income status is high, they might test out of the VA. Those patients tend to have private insurance, and so it tends not to be an issue. The VA is pretty generous, but that is one caveat that you might hear of.
Thank you both very much for the wonderful presentation. I encourage everybody to check out our future talks that are coming up from ACI Alliance and our Tuesday talks. They're here on the screen. And you can also visit our website to register, and that's at https://www.acialliance.org/ oh, that what's on my script is actually different than what's on the screen, but the Tuesday talks is right there. That's the link. And then to register, instead of Tuesday talks, it's /survey. And we'll post the link to it's complicated HTML speak. So we'll post the link somewhere for people to go to.
Great.
Thanks so much
Thank
for
you,
having us.
everybody. This ends our webinar.
Thank you.
Thank you very much.